Dear students, dear colleagues, we start the 5th year education, first semester, and this is the first lecture in psychiatry, and the today's lecture title, Introduction to Psychiatry. I would like to summarize some important aspects of basic knowledge of psychiatry. What is the topic of psychiatry? What is the subject of psychiatry? How a psychiatric patient looks like? What makes somebody to be a psychiatric patient? And we will be introduced into some important phenomena which is important to start psychiatric education. How can we define the psychiatric patient? It's very important to say that somebody is a psychiatric patient when the leading symptom is a psychiatric one, which means that there were some epidemiological studies from the 1970s, mainly from the United States, which found the fact that if you visit a somatic department, an internal medicine department, for example, and you carefully check and look for psychiatric and psychological problems, about 60% the researchers will find some mild, functionally not important, but existing psychiatric or psychological problem. Some anxiety, some sleeping problems, some sexual disorder, some small change in the mood, etc., etc. It doesn't mean that 60% of the whole population is a psychiatric patient, but we speak about a psychiatric patient in the case when the patient suffers from a serious and disturbing psychiatric problem, and it makes and leads to a disturbed functionality in everyday life. What makes somebody to be a psychiatric patient? And here we can identify 4 groups or 4 clusters of problems. The first are the experience symptoms, the second are the behavior symptoms, the third one, symptoms of cognitive functioning or symptoms of intellect, and the last one is social adaptation. Let's see them. The first, the most significantly important experience symptoms, which means that the patient experiences something in his subjective world which makes a suffering, which results in suffering, and which many times leads to a disturbed functioning in everyday life. The first symptom I would like to introduce and teach you is hallucination. Maybe everybody knows this symptom. By definition, hallucination is a perception without an outer object. For example, if somebody hears a voice which nobody has said, this is called an acoustic hallucination. If somebody sees a live tiger coming into a room and there is no tiger, then it's a visual hallucination. If somebody smells different odors which are not existing, this is called olfactory hallucination, and here we can mention that some cases olfactory hallucinations can be symptoms of epilepsy. You should be carefully cautious in the case of olfactory hallucinations and do an EEG to exclude epilepsy. Or if somebody feels something on his skin or under his skin, this is called tactile hallucination. Here we can learn a psychiatric symptom which is called egg bomb symptom, when the patient feels insects, bugs moving under their skin, and this is called the egg bomb symptom. In many cases, vascular dementia or schizophrenia can be the background of this symptom. And the last hallucination I would like to mention, gustatory hallucinations, when the patient tastes something in his mouth which is not there. So this is hallucination. Hallucination is always a psychiatric symptom, a serious psychiatric symptom. The background can be schizophrenia or organic psychotic disorders. Later we will go into the details of this. The second symptom, as experience symptom I would like to mention, is delusion. Delusion by definition is an error of thought which it's connected to the patient's ego, and the patient cannot be influenced to give up this soul. So, for example, if somebody believes that he is persecuted by the police, followed by the police, his phone call is detected by small microphones and so on. This is what we call persecutory delusion, and if it is not true and the patient believes in it, and we cannot influence the patient to give up this irreal idea, then this is a form of a delusion. Or if somebody believes that his partner, his wife, or his husband is unfaithful, and in reality this is not true, this is called delusion of jealousy. Or if somebody believes that a person in a hierarchical position loves her, this is called erotomania. And there are many other forms of delusion which later you will learn and we will teach, but the definition is very important. So delusion is an irreal thought which influences the patient behavior, it's connected to his ego, and the patient cannot give up this idea. The third symptom, experience symptom in psychiatry, which I would like to mention, is anxiety. The first two, hallucination and delusion, as you can imagine, is always pathological and rare, because this happens only in some cases of psychiatric patients, but anxiety is a different issue, because all of us, the whole population, many times experiences and will experience anxiety. So it's a normal phenomenon, it's an adaptive phenomenon. Anxiety is needed for everyday life, and anxiety in some cases is useful. It is called the adaptive function of anxiety. If you have a very small inner tension, it makes you work better. If you have a small inner tension, it will make your lecture to be better compared if you are not dealing at all with the lecture. So anxiety can be good, it can be adaptive, and it can be useful. But in many cases, anxiety is so intensive, so strong, so intense, which makes serious suffering for the patient, and it doesn't increase functioning, but decrease functioning, and this is when anxiety becomes pathological. And this is what we see in many psychiatric patients, that anxiety is a very common psychiatric symptom. It can be seen nearly in all psychiatric disorders, and there are a group of anxiety disorders when the anxiety is a leading symptom. There will be a separated lecture on this. For example, in panic disorder, you see so-called anxiety attacks with palpitation, tachycardia, chest pains, sweating, dizziness, and with other symptoms. When anxiety is so intense that the patient seeks for help. So this is anxiety. The next two symptoms are hyperthemia and hypothemia. The name of the normal mood is euthymia. Hyperthymia or hypothemia means that there is an elevated increased mood, and hypothymia means that there is a decreased mood. In most of the cases, and this is what most of the people know, the cause of hyperthymia is the manic phase of bipolar illness. But it is true, but in not all cases this is true, because there can be some other causes of hyperthymia. For example, psychostimulants can cause hyperthymia, or hyperthyroidism, the increased functioning of the thyroid glands can result hyperthymia. And compared to, and also in hypothemia, what we see that not only depression, not only unipolar depression, not only bipolar depression causes this experience symptom, hypothymia, but other causes, for example, hypothyroidism or Cushing's syndrome or steroid treatment, also can result the decreased mood symptom, which is called hypothyroidism. Phobias. What is phobia? Phobia is an irreal thought where the patient is aware of the irreality of this thought, but the patient cannot do anything against it. For example, if somebody has an irreal fear from something, has a fear going to the arcade department store or jumping into an elevator, and the patient knows that there is no danger there, but cannot do against it, then this is the definition of phobia. There are 3 forms of phobia. Agoraphobia, which is a fear from different spaces. Social phobia, when the patient has a fear from social communication, giving a lecture, talking to others, etc., etc. And specific or simplex phobia, when the patient has fear from horses, dogs, or different other things, for example, thunderstorms. Obsessions and compulsions as 2 last experience symptoms. Obsession is an errors thought which disturbs the patient. The patient knows about the reality of that thought, but cannot do against it. For example, the patient needs to think again and again of the death of his father. He loves his father, he doesn't want his father to die, but he cannot resist to repetitively think again and again on this. This is an obsession. Compulsion, when the patient needs to do repetitively something which disturbs him, which is meaningless, but the patient cannot resist to repeat and repeat and repeat and repeat it again and again. For example, the patient needs to check the door or the gas or something else. He knows that he closed the door, he knows that the gas is closed and shut down, but he needs to repetitively check it again and again. And these symptoms can be very serious. Maybe you have heard about that obsessions and compulsions work together, and this is called obsessive-compulsive disorder, when these 2 symptoms together form an illness which is called OCD, or obsessive-compulsive disorder. Here you see a famous painting by a Hungarian painter. Maybe you are familiar with his name. His name is Csontváry. He was a great Hungarian painter who started his whole career with a hallucination. When he was a young assistant in a drugstore, he heard the hallucination, he heard the voice, he told him, "You will be the greatest painter in the world, you will be greater than Raphael." And he started to paint, and he started to draw, and he started to learn painting and drawing because this hallucination led him to this way. So this is an example for hallucination. The second issue which makes somebody to be a psychiatric patient is behavior, change of behavior. For example, aggressive hostile behavior. In some cases, aggressive hostile behavior is based by psychiatric problems, based by psychiatric disorders. For example, if I get a phone call from somewhere that at the Széchenyi Square at this moment there is a person who in swimsuits tries to ride the Hunyadi statue, the horse statue, and yelling that he will be the leader of the city, then without any psychiatric examination, I can be very much sure that this patient suffers from psychiatric problem. Maybe he's manic, maybe he's drug intoxicated, maybe he suffers from schizophrenia or something like this. But the whole behavior, the whole strange, bizarre, aggressive, and sometimes hostile behavior can lead us to the fact that maybe this person suffers from a psychiatric symptom, a psychiatric illness. In many cases, there are aggressive and hostile persons who do not suffer from psychiatric illness, but in some cases, this is the background. Or another example, postpartum behavior changes, for example, which is a good example for behavior symptoms which forms somebody to be a psychiatric patient. There is a young mother who gave birth to a baby, and 5 days after delivery, the mother at the 5th day doesn't care for the baby, doesn't breastfeed the baby, don't bother at all with the baby. The mother who in the previous 4 days was a perfect and excellent and caring mother. So this rapid change of behavior many times can make us sure that the mother starts to suffer from a serious psychiatric illness. Later we will learn that there is an illness which is called postpartum depression or other postpartum psychosis, and this rapid change, dramatic change in the behavior is resulted by these psychiatric illnesses. The third cluster, the third issue which makes somebody to be a psychiatric patient is the symptoms of cognitive functioning, intellectual functioning. And here we can learn two great syndromes, which is important. Later there will be separating lectures on this, but in this introduction I just very shortly mentioned this. The first group or syndrome is intellectual disabilities. Previously it was called mental retardation. When somebody's intellectual development is stopped very much earlier than it should be. So if somebody's intellectual development is stopped around the age of 7 or 8, then what we see at this case, mild intellectual disability, which was previously called debility. Here the IQ range is between the 50 and 70. You should know that the normal IQ, the normal intelligence quotient is 100 and 110, around 100, 110. If the IQ is between 70 and 50, then we speak about mild intellectual disability. If somebody's intellectual development stops around the age of 5, then we speak about moderate intellectual disability. Here the IQ range is between 50 and 30. And if somebody's intellectual development stops around the age of 2 or 3, then we speak about severe intellectual disability or idiocy. Here the IQ is under 30. This is the intellectual disability or mental retardation syndrome. We will learn the details much later during the second semester. There is another group of psychiatric patients, other group of intellectual cognitive function patients when we speak about dementia. In the case of dementia, the person reached a high or average intellectual level, and there is a serious and rapid or significant cognitive decline, and this is when we speak about dementia. The patient suffers from serious memory loss, short and long-term memory loss, and a decline of the problem-solving intelligence and different cognitive functions are disturbed seriously. And the most common cause behind the dementia syndrome is Alzheimer's disease, or second is vascular dementia. Alcohol is a very important noxa which can lead to this syndrome. And the last, beside experience, behavior, cognitive functioning, is social adaptation, because we have many social roles. If we do not fulfill our social roles, as the mother in postpartum depression, not able to take care for the baby, then this social disadaptation, this inability to fulfill the social roles, can give us the information that maybe a psychiatric problem is starting and beginning to develop. And this is what we can see in many psychiatric patients. Okay, as a second step, we have to learn in these introductory lectures that there are two major groups of psychiatric illnesses. We can say that all the psychiatric patients can into two big baskets, can into two big groups. The one group is the psychotic patients, the other group is the non-psychotic patients. And what is psychosis? Psychosis, by definition, is a serious disturbance of reality testing, and the background of this serious disturbance of reality testing is some psychiatric symptom. For example, if somebody hears a hallucination which tells him that the hallucination is from the Mars, and tells him that he is an agent from the Mars and he needs to do something because he got a message, and the patient starts to believe that he is a secret agent from the Mars and he has a special duty to do, and etc., etc., then this patient is psychotic because his reality testing is seriously disturbed because of a psychiatric symptom, because the reality is that he is not an agent from the Mars and nobody is talking to him. He's just hallucinating. He has a perception without an outer object, as we have learned the definition of hallucination. So this is a case of psychosis. Or if somebody develops an idea that the police follows him and would like to kill him, and it is not true, then he has a delusion. He has a persecutory delusion, and he is psychotic because he has a serious disturbance of reality testing due to a psychiatric symptom. Because the reality is that the police don't want to harm him. So this is the definition of psychosis. In the case of psychotic patient, the symptoms are egosymptomic, or which means that the patient is same with the symptom. He's identical with the symptom. As I believe that I'm a lecturer in psychiatry, the psychotic patient believes that he is an agent from the Mars. And he has the same relationship to his pathological identity as I have a relationship to my normal identity, that I am a lecturer in psychiatry in the University of Page. So this is what ego symptoms means. And due to this, there is a lack of insight of the illness. That these patients are unaware of their symptoms. They do not believe that they have psychiatric symptoms. They believe in their psychiatric identity, their psychotic identity. They believe in their delusions. They believe in their hallucinations. And this is what is very much problematic. Other group of psychiatric patients are the non-psychotic patients who has many symptoms. They are anxious, they cannot sleep, which we call insomnia, or they are socially avoidant, or they lose their appetite, etc., etc. And they know that they are ill. And they has an insight on their problems. And they do not lose their reality testing, so they are not psychotic, but they are non-psychotic. And this is another group of patients. Very important at the very beginning to learn these two groups of patients, because you need a very much and very different approach to the two patients. To the non-psychotic psychiatric patients, your approach can be the same as you have your approach with other patients in different somatic departments. That you are a practitioner, you are a doctor, you are a medical university student, and he is the patient, and everybody knows his role. And you can stay in the medical professional or the healthcare professional role, and the patient will stay in the patient role. In the case of psychosis, this is much different. If you approach a psychotic patient with the position that you have delusion, and I am a practitioner and I am a physician, that many times the patient will reject further communication. Somehow, with the psychotic patients, you have to communicate as accepting their irreality. Do not argue with it. Do not go against the symptoms, but try to understand it, try to accept it, and the patient reliance, the patient trust will be developed by this different approach. So this is why at the very beginning we have to learn that psychotic patients and non-psychotic patients are quite different, and your communication, your approach towards the patient is also quite different. The details and the practice of this will be introduced during the classes and during the practices. Okay, let's see the most important psychotic symptoms and syndromes. Hallucinations were also mentioned, already mentioned. Here we can mention a very important and dangerous symptom, which is called comment hallucination. So the patient hears a voice which instructs him to do something. For example, the patient hears an acoustic hallucination which tells him to kill somebody or to kill himself and commit suicide. This is very dangerous psychiatric symptom, and comment hallucination should be very well diagnosed and intervened in many ways. Delusions. There are two big groups of delusions. We have learned that delusion is an errors thought, which is connected to the patient's ego, and the patient cannot be influenced to develop this thought. These are delusions which are nonsense, which can never happen. That I visit the Pacific Ocean every morning and have a discussion with sharks and coming back for lunch. It's impossible. And I have heard this from a patient. And the second big group are the non-bizarre delusions, which can happen, but which are not true in the case of a certain patient. For example, somebody complains that the police would like to kill him, and it is not true. Or somebody believes that his wife is unfaithful, and it is not true. These are non-bizarre delusions which can happen in everyday life. Disorientation, which means that the patient doesn't know that which date is it, where is he. For example, he believes that it's not 2020 and page, but he believes it's 1974 and he's in New York City. So this is a disorientation in time and place. And then delirium is a kind of cloudiness of sensorium, and Korsakoff syndrome, which is an amnestic syndrome, amnesic syndrome. We will learn the details later, and during the practices you will learn these. Let's see a few non-psychotic symptoms, and the patient has an intact reality testing, the patient has an insight on the problem, and the patient knows that he has a symptom which is not saying anything. So the symptoms are ego-dystonic and not ego-symptomic. In psychosis, the symptoms are ego-symptomic. In non-psychosis, the patients are ego-dystonic or ego-alien. For example, anxiety, the patient experiences a tension and they know that this tension is disturbing, and he recognizes that he doesn't need this feeling. Or the patient cannot sleep, which is called insomnia. Or the patient has hypothymia, low mood, decreased mood. Or phobias, which we have already learned. Or obsessions or compulsions. Or sexual disorders, for example, erectile dysfunction or anorgasmia or other sexual dysfunctions which disturbs the patient, and or eating disorders. The details you will learn later in the lectures, during the lectures, and during the practices. And at the end of this lecture, I would like to touch another point. We have learned about negative things. We have learned about deficits. We have learned about disturbed realities testing. We have learned about dysfunctioning, we have learned about degrees of intellectual functioning and so on. But in the case of psychiatric patients, we have to emphasize that in many cases, psychiatric illness has a positive advantage, has a positive result. And this was discovered by the Greek philosopher Plato, and later Lombroso and others during the 19th century emphasized this, that creativity, high level intellectual or artistic creativity is connected sometimes, in some cases, to psychiatric diseases or psychiatric illnesses. It doesn't mean that all psychiatric patients are genius and all psychiatric ill individuals show some talent. It's not true, most of them do not. But there were some examples, and there are some overlaps between high functioning in the field of art or science and psychiatric illnesses. And let's see a few examples. For example, Vincent van Gogh was a great painter. He suffered from depression, and he committed suicide, and he cut down his ear and gave it to Gauguin, and you know this story. And he was a great painter. Or John Nash, a famous film, a great mathematician, is an example for a highly talented mathematician who suffered from schizophrenia. Or the Pink Floyd guitarist Syd Barrett, who also suffered from schizophrenia, and his talent led to a very strange and very idiosyncratic and very interesting music, which was done by the Pink Floyd group. Or Friedrich Nietzsche, who was a great philosopher in the 19th century, and he suffered from psychotic symptoms at the end stage of his life, and later developed serious dementia, and he was the most influential philosopher during the 19th century. And Sylvia Plath, who is a great American poet and writer, also committed suicide and suffered from depression. and she also shows an overlap between creativity and psychiatric illnesses. So this was a short introduction to psychiatry. This was the first lecture at the 5th year, first semester, and you will meet your practice leaders during this week, and we will continue with the lectures by this way. So thank you for